You guys, thank you so much for having me today and letting me talk about our work on modeling the benefits of coverage for weight loss drugs. I think that the order of today is so perfect, at least for my presentation, because I think we'll have a lot of fun talking about weight loss drugs and all of the hype around Ozempic and stuff like that, but really the framework that we're using to look at the benefits of coverage is not at all new to weight loss drugs, right? So the initially high list prices and the hysteria around budget impact and stuff like that is not new to weight loss drugs. And my colleagues at the Schaeffer Center, along with Thomas, have been studying and talking about this stuff for years and looking at it within hypertension, HIV, Hep C, and many other drug instances. So today we'll focus on weight loss drugs, but this same idea expands well beyond just weight loss drugs. So am I able to advance slides from here?
Yep, that's the next one.
Okay, so the work that I'm going to share today, the results that we'll talk about and stuff like that are all from a white paper that my colleagues and I at the Schaeffer Center put out last spring, modeling the benefits of Medicare coverage for weight loss drugs. And I've added in a few extra set of results so we can sort of talk about more broad access in general. And then if we, is this, okay. So the game plan for today is to just cover quickly the current state of the obesity epidemic in the US, then touch on some of the policies impacting the insurance coverage for these drugs, then go over how we've chosen to model the benefits of broad access or of insurance coverage, then run through the results from that modeling and talk about the policy implications. Okay, so obesity rates in the US have been rising since roughly the 1980s. And I think most of us have probably heard the statistic that over 40% of adults in the US are obese. And so that obesity threshold is really a BMI of 30 or greater. And what we have graphed here is the average BMI in the US. And as you can see, that's been climbing over time too. And we're just hitting the point where the average BMI is 30. And of course, in the status quo, again, without new interventions, this is projected to continue to climb over time. And what's hidden in a lot of these statistics is the fact that obesity disproportionately impacts minority populations. So here we have obesity rates by race and ethnic groups. And so on the far left there, we have obesity rates for Blacks, Hispanics, and whites. And what you see is in the Black population, obesity impacts 60% of adults, whereas in the Hispanic population, it's 51%, in whites, it's 41%. And although that variation is rather shocking, I think what's even more alarming is the variation. We see the variation is concentrated in the higher BMI category. So it's really once you hit a BMI of 35 or greater where we really start to see the disparity across race and ethnic groups. And those are the categories where you have the increased health comorbid conditions like diabetes and heart disease. So it shouldn't be surprising then that once we model these comorbid conditions to obesity, that we see both disparities again in the rates, but also high rates. These rates have been growing over time too, just alongside the obesity rates in the US. And so this is important to note that the previous slide had rates for the entire population. We're looking now at these disease rates within the Medicare population, as the onset of these diseases tends to be later in life. So the graph is a little bit more compelling if we focus on that population. But again, we see the disparities in the minority populations for diabetes, hypertension, heart disease, and disability. So again, we're just sort of creating the story around the burden of obesity in the US right now. what we need to also talk about is not just how obesity impacts the chronic conditions, but also that obesity is associated with shorter lives, reduced life expectancy. And this graph is pretty intense. It's a figure from a JAMA article, but what it's showing us is the years of life lost on the vertical axis associated with each BMI level, where each one of the bars represents a 10-year age range. Lightest is younger and darker is older. But if we focus in here on the BMI of 40, we can see that if you become obese in your 20s or your 30s, having that high BMI is going to be associated with 6 or 8 years of lost life. So there is definitely a mortality impact with obesity. Then finally, as economists, we also want to think about how obesity will impact, I think I'm changing the slide here, health-related quality of life. And so a prior health affairs study looked into this, comparing different sort of ailments and looking at which one had the greatest decrement to health-related quality of life. And they found that having a BMI of greater than 30, again, that's the obese range, had a bigger impact, a bigger decline in health-related quality of life than aging from 30 to 50. So there's a lot of students I know online and in the room. And so if you haven't hit that age decline yet, we can also look at the comparison between being obese versus being a current smoker and seeing that it's much worse for your health-related quality of life to have obesity versus being a current smoker. So to just sort of summarize all of this, we have this huge burden of obesity in the US, and it's not new. We've been sounding the alarm for decades, and the status quo policies aren't making a dent. We keep outpacing our projections on obesity. And so we have medical associations doing their best to raise awareness, government agencies doing the same, and yet still obesity is oftentimes viewed as a lifestyle choice rather than a disease and a serious health concern. And all of this creates stigma around the patients and the treatment. And uptake of available weight loss drugs has remained exceptionally low. As we have had the introduction of the new GLP-1 drugs, we're seeing a little bit of an increase in uptake. So that 3% comes from, I think 2018 or 19 GAO report. And in the last few years, we've definitely come up from 3%, but it's still very low. And this all feeds from the fact that there's not access to the drugs. Medicare is explicitly excluded from covering weight loss drugs. And then private insurers either, following Medicare's lead or for many a host of other reasons is also often not covering weight loss drugs. So all of this seems rather depressing, but there are a few policy levers available to impact coverage and access for weight loss drugs. And so, as I mentioned before, Medicare has a moratorium on coverage for weight loss drugs, but there is legislation in Congress right now, the Treat and Reduce Obesity Act, that would overturn that, and it would allow access. It would allow Medicare to cover weight loss drugs. It would do a few other things in terms of expanding coverage for intensive behavioral therapy, but importantly, it would allow coverage. There's also a less discussed policy route, but the United States Preventative Services Task Force is a group that puts out recommendations on preventative services. So things like breast cancer screening and colon cancer screening and all that sort of stuff. They review the evidence and then give a grade to whether or not that service is the benefits outweigh the costs, and if a preventative service gets a grade of A or B, the Affordable Care Act requires private insurance plans to cover that service. So in the past, the Preventative Services Task Force has looked at weight loss drugs to prevent obesity-related morbidity and mortality. And the most recent recommendation was posted in 2018, and it looked at pharmaceuticals, but only gave a grade to intensive behavioral therapy. And at the time, they concluded that the pharmaceutical interventions, the side effects did not outweigh, the benefits did not outweigh the potential side effects from taking the drugs. So since 2018, several new drugs have hit the market. So there's hope that in their next update of their recommendation, that they might give a recommendation to pharmaceuticals that could trigger coverage from commercial insurance.
Alison, just a point of clarification, the Services Task Force is allowed to mandate non-services such as medical products like drugs, and is that in their charter? Like, I mean, the ACA, they can recommend a drug and then insurers have to cover that, or I thought the formularies and stuff determined, or the benefit managers determined coverage as opposed to the task force. So is that only for services, or can they actually extend to drugs?
I believe it can extend to drugs. That's my understanding, and having read the report on this, is that they can give, I'm trying to think of an example where they have recommended a drug and not just a service, and in a way, these obesity.
Anyways, we don't have to spend time on it. I'm just curious if that,
Yeah, I mean, I think it's a great point, and there's not that many examples where the recommendations do cover drugs versus services, but in the language in the current recommendation, they discuss pharmaceuticals and just talk about how at the time the available drugs did have high side effect profiles and didn't result in very much weight loss. And so that report came out before the advent, or the introduction, I should say, of the GLP-1 therapies that we're all talking about today. So it included liraglutide, which is better known as Saxenda, which is the predecessor to semaglutide, which we all know as Ozempic, which is the diabetes. The semaglutide is marketed under the name Ozempic for diabetes, and marketed in a higher dose under the name Wegovy for obesity. And then again, the same active ingredient is used in Rybelsus, which is the pill format of this drug. So prior versions are injections, weekly injections, and Rybelsus is not as effective, but it sort of shows where the market is heading for weight loss drugs, and hoping to find an oral version that is easier for patients to take. But so semaglutide is Novo Nordisk's drug, and then tirzepatide has been more recently approved by the FDA under Mounjaro and Zepbound, and it's a little bit more effective even, and marketed, it's Eli Lilly's drug. I have quickly, you can see just some of the clinical trial results, but Wegovy resulted in a 12.4% weight reduction compared to placebo in its sort of initial weight loss clinical trial. So this would be folks with obesity but without diabetes. And then more recently than that, it's been shown to have some cardiovascular protective characteristics also. So they tested Wegovy in patients with heart disease and looked at the reduction in cardiac events. And so that's the most recent Wegovy indication. Tirzepatide has had an even bigger impact on weight loss. And so in their registrational clinical trial, patients saw 15 to 21% weight loss reduction. So these new weight loss drugs really are more effective than anything we've seen in the past, which is why the conversation has heated up over TROA and some of these other policy levers for coverage. Okay, so given the new drugs and their ability to impact weight in ways that are approaching, you know, the gastric bypass surgery results and stuff like that, at the Schaeffer Center, we wanted to look at and try to model the benefits of coverage. So look specifically at the cost offsets, but also at the social benefits of widespread access. And we initially did this looking specifically at the Treat and Reduce Obesity Act. So looking at what it would mean for Medicare if they allowed coverage for weight loss drugs. So looking at the cost offsets for Medicare. And we used our microsimulation model, the future adult model. And that allowed us to sort of look at different insurance coverage scenarios, whether it's Medicare by itself or looking at private insurance also, and sort of explore how the benefits of coverage varied by different population subgroup. So just quickly to step back and tell you in one or two bullets about our microsimulation model, and we can certainly go over this in the questions if people have more specific or detailed questions about the microsimulation model, but it pulls on data from a number of different nationally representative surveys. So the base of the future adult model is the panel survey of income dynamics. So that's looking at everybody in the US over the age of 25 and pulling in information on all kinds of patient details, whether it's economic or household, all of that stuff. And then we bring in information from the NHIS on health trends, and then use MEPS and MCBS to look at healthcare costs, and then bring in additional data from elsewhere. But really what we're trying to do is use these historical responses to the surveys to simulate and predict what future responses to those surveys will look like. And I think it's important to note why we use microsimulation to model the benefits of coverage for obesity. And I think there's three important things or maybe four, when modeling obesity. And one of the first ones is that treating obesity has long-term benefits, right? So if somebody loses weight tomorrow, their medical care costs might not drop immediately. What we're really measuring is the reduced incidence of these chronic, costly conditions like diabetes and heart disease and hypertension. So we need to look more than 1 year into the future. We need to look 10, 20, 30 years into the future to really get a sense of what the cost offsets will be and what the social benefits will be. Then even beyond that, there's unique aspects to this obesity drug market in that there's a huge cash pay market. So most people don't have access, but we have probably all seen the articles that many people are paying out of pocket to get access to the drug. So if we just looked at some claims data and tried to look at costs year over year for people taking the drugs, we would miss everybody who's only in the cash pay market, which would certainly bias our estimates. And I think also important to note that even if we wait until some data source has enough data like MEPS or something like that, that would capture both the commercial and the cash pay market, we still would have a selection bias issue in terms of who's selecting into taking the drug. So microsimulation really allows us to look at what we see the current relationship between BMI and other health and economic outcomes and use that to project what's going to happen in the future. Okay, and then just quickly to note, when I am talking about our microsimulation model at USC, this is not something that I dreamt up in my home office. This has been in development since 1999 with funding from NHIS and the MacArthur Foundation, National Academy of Sciences, and has been published very, very widely. So don't take my word for it. It's instead trust that it's been well vetted. There is a technical appendix online if anybody wants to nerd out in all the details of it. I can be happy to send that to you. Okay, getting into specifically what we modeled for the paper we're discussing today is we looked at 4 coverage scenarios. So first of all, we modeled the status quo, which is no change to what's going on right now. That's looking at low levels of coverage and just modeling people on their natural weight trajectory over time. And then from that, we did a Medicare coverage only scenario. So this is, let's assume TROA is passed, but nobody else changes their coverage plans. And what we modeled was a 20% reduction in BMI, consistent with some of those clinical trial results for tirzepatide or Zepbound. And we modeled patients getting that 20% BMI reduction and then maintaining it, but allowing some variation in BMI over time. So we allowed patients to gain up to or lose up to 5% of their post-treatment BMI. So we allowed a little bit of natural variation. And I point this out because it's just in contrast to how it's been modeled elsewhere, like in ICER and other reports. So,
Alison, there
yeah.
seems to be a jump here that I missed. So Medicare coverage, I guess, is going to increase utilization because you show a reduced BMI. But, you know, the Europeans' utilization is not great. I mean, their system for dealing with pharmaceuticals and other procedures and therapies is to restrict purchasing. I mean, they want to use their monopsony power. They want to squeeze the suppliers. So it seemed to me, I would say that you want to consider a scenario where Medicare coverage actually reduces utilization.
Fair point. What we're doing here is we are modeling the total benefit available if access was provided through insurers. So I think there's a lot of nuance to how uptake would happen, and we can have arguments over what the uptake rates would be, what the adherence rates would be. We've sort of set all of that aside and are trying to make a point around, you know, obesity has this huge burden on society, and
but then
widespread access would have tremendous value. And then there is sort of the details of working out what the, you know, buyer's club or other setup is to allow the maximum amount of access.
It seems to me you could just say, look, I'm going to simulate a 20% BMI reduction that comes from increased utilization. And then it's a separate economic question, what increases utilization?
Sure.
You're jumping to this word access. It sounds like a great word, but we've seen in practice that access can mean reduce utilization and reduce innovation and things like that. You don't need to make that jump to use your simulator and teach us some excellent lessons.
I think
Sure.
I think it's particularly important because this is the largest selling drug in the world, and Medicare IRA, the Inflation Reduction Act, is going to go after top spenders. So this is definitely going to be in the IRA if it comes in. And then the question is, what happens to innovation if it's included in IRA? And maybe these drugs get more utilization, but future drugs don't appear as much.
Absolutely. And CBO has mentioned in their estimates, I think it's available for negotiation in IRA in like a couple years. Is that right? I think they're modeling somewhere maybe 2028 or 2027 that it might fit negotiation. But yeah, what we're saying here is that what we're modeling, to change my language, is that patients get access to weight loss drugs once they have coverage from Medicare. So for most people, that's once they're age 65, and for people with disabilities, it's sooner than that. We've modeled all of them. The intervention is that once they are on Medicare and have a BMI greater than 30, they have access to our hypothetical weight loss drug here, the 20% BMI reduction. And we also allow, consistent with the labels for these drugs, a BMI of 27 and a comorbid condition. But so our first treatment scenario is modeling use for that patient population. And the second scenario is modeling that same patient population having access, but also private insurance coverage too. So many people are predicting that commercial insurance will follow Medicare's lead here. And if that happens, we're looking at what the benefits will be to Medicare in particular if patients have access to this drug before they hit 65. So Medicare is getting much healthier patients. And then finally, we have a universal access scenario where we fold in the Medicaid patients and the uninsured. So this is just treating everybody in the US who fits the indication for weight loss drugs. Okay, so jumping into the results from those sets of simulations, what's shown in the table here is the cost offsets to Medicare from both the Medicare only coverage and the Medicare and private insurance coverage scenarios. And so these are all modeling the cost offsets. So we're looking at the costs and the status quo and comparing them to the treatment scenarios. So what you see is that in 10 years, with Medicare coverage alone, that Medicare stands to, Medicare would see $176 billion in cost offsets. And below that, we break it out into Medicare Part A, B, and D. And that's because a lot of the conversation around budget impact has been on the solvency of Medicare. And this shows that the savings are accruing largely to Part A, which is where that conversation is rooted. And I might be getting into the weeds, but Medicare Part A is funded through the Medicare Hospital Insurance Trust Fund, which doesn't have the ability to expand its revenue source. So it's based off of payroll taxes, whereas the costs of these drugs, although we didn't model them, they will come through Part D. So there is a little bit of a financing part to coverage for weight loss drugs that will help long-run solvency for Medicare. But I think even more important than that is to notice two other things about the Medicare cost offsets. One, as if you look out to 20 years, the cost offsets grow to $479 billion, which is not just twice 176 billion, right? So it's not a linear increase there. The cost offsets are growing over time as more patients have treatment and are delaying or preventing onset of chronic conditions. It's also important to note that the cost offsets grow even more if you include private insurance coverage. And again, that's because you have more patients entering Medicare much healthier than they would if coverage was restricted until you hit Medicare eligibility. And then lower in the table, we show the cumulative health benefits, which is really like the health-related quality of life piece of all of this. And then the cumulative social benefits. And this, you see in 10 years, with Medicare coverage alone, again, so this is just getting coverage when you become eligible for Medicare, the social benefits are $1 trillion. And if we do the crude division of by 10, that's $100 billion in social value per year from Medicare coverage alone. And so if we think about that being the total value, and we need to divide that between consumers and producers or manufacturers, I think there's a lot of room to negotiate, especially if you think about the highest grossing drugs in the US are in the 20 billion range.
But I'm confused here. The health benefits are, I mean, there's a important personal element of it, but you start out by saying these drugs are not passing the market test in terms of the insurance delivery. So one slide seems to say these things are awesome for individuals, and the other slide was saying individuals aren't taking it. So how do I fit those together?
Insurance isn't covering them, right? So we're looking 10, 20, 30 years out.
But
into the
insurance
future.
doesn't think it's awesome. I mean,
No, insurance.
you think it's awesome and the insurance doesn't think it's awesome. Isn't that a fair characterization?
Yes.
You mean private or public?
Private.
Yeah. Well,
Right.
they don't see the benefits if it's a long run benefit. That's the one issue. That why the private, even if it's a long run benefit, it might not be covered.
But don't they have customers who?
Well, the
Right.
thing with insurance is that you're likely to change insurance every 4 years. I think that's how long people tend to stay on their insurance plans right now. So the incentive for private insurance to cover this is low if they are the only ones covering it. And so we have that piece of all of this that we need to have widespread access before any one insurer plan can start to
Well,
recuperate.
that
the
answer
benefits
seems to
they're
say
covering.
that the benefits in this health benefit row are not really personal. Because when people change plans, they still keep their body.
Oh.
I mean, so
The cumulative health benefits are the these are just the quality benefits.
I know, but the people value that. I mean, and they're going to be willing to pay for it. If it's really had benefits of this magnitude, they should be willing to pay for it. But we don't see, they're not flocking to plan and say, hey, plan, you're going to charge X more per month. I want to have it because you cover Ozempic. They're not doing that. Or they are, and the insurance companies haven't woken up to it. But I mean, it has failed the market test so far.
I mean, put it this way, there's some redistribution that takes place, right? There's some people that cannot afford this, but the government taxes the rich and funds Medicare. But just think about the rich population to isolate Casey's point. The rich population in Medicare can make a choice to do this on their own, or they can send in taxes to Medicare to do it for them, essentially, right? So the question is, if you just think about the rich population, why would this be beneficial at all when the government comes in and control prices, etc.? If they have to fund their care either in Medicare or they have through taxes, they pay a mandatory premium to Medicare, essentially, as opposed to a volunteer premium to a health insurance plan.
Yep, but we are seeing the wealthy move to the cash
I
market.
know, but then there would be no effect on access, right? So the question is the access all because of the redistribution of the program, or like what is driving this? Because Medicare is not free. People are paying for it. So, you know, they either pay for it in the private market or they pay for it in taxes. And usually we think the private market is a little bit more efficient in doing things.
Yes, and I think it's important to note in what you're seeing here is the cost of the drugs aren't in our model right now. So that's why we're not talking about value and we're talking about benefits. If we multiplied the number of people that we're assuming take the drug by the list price of the drugs, these are not positive numbers. So it's looking out at the net price right now is much lower than the list prices. And what will be the price in 10, 20, and 30 years is not known right now, but it will be much lower. And so we can jump ahead just to look at, this is the annual benefit by age on the left here. And then we'll look at it by age and BMI on the right. But this is starting to show you, so again, no price of the drug is baked into any of this yet, but we see that the benefit, if you treat somebody who is Medicare age and older, is below what even the current net price of these drugs is. And that the real benefit of treatment is in treating patients earlier in life and preventing all of the chronic conditions and other things associated with being obese. And so whether or not that's delaying or preventing diabetes or future joint replacements, all of that sort of stuff, the true benefit from these drugs is in early treatment. And also, whenever you sort of have an introduction of a new and expensive therapy, the first thing within people's mind is to restrict access and only give it to the people they think need it the most. And that's a bit of what's happening in the slide before that I showed you, is that we're looking at every person taking it. I think as we learn more about the drugs, we'll understand where the value is greatest in treating patients. But this graphic shows us that if we think about treating, I think everybody's natural instinct would say, well, we should treat the most obese patients first. And what this shows is that the people who stand to get the greatest benefit are actually those people in the more moderate BMI bands, whether that's 30, sort of between 30 and 40, the drugs make a bigger impact.
For the insurance groups here, I just want to make sure that I'm clear. When you showed Medicare and then Medicare plus private insurance, is that traditional Medicare plus like a Medicap plan or something that's supplemental, or are you including Medicare Advantage and managed care in these groups as well?
Well, so this graph is just showing, this would be sort of the universal access. This is treating everybody and then looking at the social value by different subpopulations. Back in our Medicare cost offsets table here, this is looking at everybody who has access to Medicare.
Right, but is there a difference between your Medicare column and then your Medicare, what I'm assuming, plus private insurance? Like
The
coverage
Medicare
level?
plus private insurance includes everybody who has private insurance instead of Medicare. So that's me and probably most of you. I'm not 65. So, and I'm not disabled, so I don't have Medicare, but I have private, so I would be included in that simulation versus not in the Medicare only.
Won't the market give access? I'm not sure exactly what access means, but won't the market be giving it in about 10 years when this thing becomes generic? So doesn't the baseline already have a heck of a lot of access in it?
I think right now I've seen estimates that maybe 20% of private insurance is covering these drugs.
No, but I mean, 10 years from now, it'll be generic. So you could pay the list price, but it's going to be low.
Yes.
So that's what I'm saying. Is that built into the baseline that these drugs will be cheap, even in the baseline, once we go beyond the year 2034?
Well, I'll say it one more time, but we have no drug price in this. And that's totally the point, is that in 10 years, everything will be much lower. But even before then, we're going to get the generic competition, and we can look to previous examples, whether it's Hep C with Sovaldi when it was launched at like $100,000 a pill or something, $90,000 a pill. the same sort of hysteria around the potential budget impact of that happened. And then we had a competitor enter within a year and prices started to fall dramatically. Here we already have two competitors and the pipeline is rich. So I think the prices are going to fall dramatically before you hit generics even. So.
But my question, just technical, what do we mean? Simulation is always a difference between a scenario and a baseline. And
Yeah,
I'm asking, does the baseline have access in it 10 years from now? Or is that, you're only turning on access in the scenario?
So the baseline is based off of nationally representative data through 2019. So the status quo or baseline is assuming low levels of coverage throughout time. So to your question, it is not turning on more access. We do have information impacting health trends, but we aren't influencing in the baseline the sort of available generic drugs. So we are looking specifically at what the value is of treating obesity versus where we're at today.
Got it.
Yeah,
Got it.
you're gonna get a too large effect relative to that effect, right? So
Yes,
the insurance coverage is gonna go up dramatically when it's generic.
yes. I mean, again, there's limitations with this sort of simulation. We'll also have new drugs. So weight loss will probably not be capped at 20% anymore. And that whatever the next version of these drugs are probably helps you lose more weight. And then maybe some of those BMI subcategories that we looked at shifts and stuff like that once, we can have a bigger impact on weight loss. So this is an example to show that there's value in treating obesity and we shouldn't assume that these will still be the drugs that everybody is looking to in 20 or 30 years, but we can look out. We've done this with other therapies, sort of looking backwards, say at statins or something like that, to see how much value they've generated over time versus the cost that they've had. And so we can do this looking back in 30 years also, but we have the data we have today. So we have to sort of use the coverage that we see in the data today to project forward versus intervening and having what is as close to a cure for obesity as we've seen, right? And there's a lot of things that we have to, our simulations assume everybody's taking these drugs. Certainly that will never be the use case, right? We will never see 100% uptake or 100% adherence. But again, in this hypothetical world where let me see if I can, I'm moving my own slides and not the slides on the screen. The slides are down now, or are they still up? I was gonna go to slide 25.
They just disappeared about 2 minutes ago.
Did I do that? Anyways.
There we go.
They're back.
Okay. So again, I think we've done a good job of sort of outlining a bit of the ways in which what we're modeling here is hypothetical, and it's an example to show the potential value, or also to underline what the actual burden is of obesity, the issue of not treating obesity, what it would be costing us. So with that in mind, under these scenarios, if we look at both private insurance and Medicare offering coverage for these drugs, over time, this is showing the 10, 20, and 30-year impacts on the prevalence of chronic diseases. So we're showing the reduction, the percent decrease in prevalence. So the vertical bars are actually reductions here. And so looking at diabetes, we see that after 20 years of treating obesity, we would have a reduction. So if we started having widespread coverage for these drugs today in 2044, 4.4 million fewer people would have diabetes, or that's the same as 45 million person years over the next 20 years, fewer with diabetes. The other part, sorry, I'm not advancing, but if we move to slide 26, because we also, as I mentioned on a few slides back, ran the universal access. So if we treated every patient with obesity scenario, these are the cumulative social benefit from treating everybody. So that's in 10 years, that's $3.9 trillion, or in 30 years, that's $17.6 trillion. And you can see the row below it is the average annual social benefit in both of those, and all of those time horizons. But the point is really that the value of treating obesity is tremendous, or alternatively, the burden of obesity on the US is high. I think that there's also, on slide 28, we've done just a cut of the benefits, so you can see that they do vary a little bit across race and ethnic groups. But more importantly, there's also a distributional piece of this where we look at the benefits for college educated versus not college educated Americans.
Should I interpret this as a study of the value of increased demand for these drugs as opposed to Medicare coverage? Because those are two different things.
I think this is the value of treatment.
Yeah, so if we hypothetically had a certain demand for these drugs, here's how beneficial it would be in terms of health and healthcare spending. Is that kind of that's not the title of the paper though, so that's why I'm wondering.
Well, we're talking about what the potential benefits of coverage would be. Are you arguing that the demand is low for these drugs?
No, the question is, what's the marginal impact of Medicare coverage as opposed to what's the impact of a certain level of demand, meaning certain fraction of the population take these drugs? So
yeah, I mean, the benefits to Medicare from the potential benefits to Medicare from coverage are the cost offsets that we showed on the other slide. And we have to use the term potential, right? Because we're assuming that.
No, but I mean, take the rich, like I said, take the rich population, right? They're gonna either take this or not, whether they're on Medicare or not. Okay, so there's no impact on Medicare on their utilization. There's zero impact on them in terms of utilization. They're either gonna take this because they like it, they don't like the side effects, they might not take it, whatever. But it's not gonna be Medicare coverage that induces them to take anything. So zero effect on Medicare Part A, zero effect on Medicare Part B. Because
I mean,
they
would still get those
their
costs
demand is
offset.
unaffected by Medicare coverage.
Sure.
So there's no impact whatsoever on Medicare because their demand is the same whether the drug is covered or not. So that's what we're having trouble with. And then you go down in the lower part of the income distribution who are implicitly getting subsidies from Medicare, and they might respond in their demand to Medicare coverage. But how do you model that? And that's sort of the title of the paper, I think, which is not clear how that translates into the numbers here.
Yeah, I would argue that not many of the Medicare age population, the demand for the drug is the cash pay market is probably fairly low within the Medicare population, but you're right in your description of what we're doing. We're modeling.
No, I mean, the title of the paper is what happens if Medicare covers this compared to when Medicare doesn't cover it.
Yeah.
And I just told you for the rich population, nothing happens because Medicare coverage is not driving their demand at all. Okay. So
Yeah, I
the question
understand.
is, how far down in the distribution can you go for that statement to be true? Certainly not true for the poorest 25%. They're going to be highly affected by Medicare coverage. So,
Yeah.
so the question is, what incremental impact does Medicare coverage have, as opposed to, this seems to say, you know, what impact does demand for the drug have, not what impact utilization, whatever you want to call it. Yeah. So utilization.
I don't know that we
Okay.
have good data on who's paying out of pocket for these drugs. So I think your research question is an interesting one, and I don't know that we have the data to correctly model that in any way to understand who's taking it right now. And we're just starting to get some of that data.
No, but you're saying there's huge benefit by Medicare covering it, right? And I just told you a huge swath of the population when there's zero effect of Medicare coverage. So you got to take a stand on how much does Medicare increase utilization or not. And for Bill Gates, it doesn't impact whether he's going to take the drug or not. So
yeah, but what percent of the population do you think is paying out of pocket right now?
It's irrelevant to my comment. I mean, my comment is about whether the drug government is going to cover the drug determines whether I actually take the drug.
Yeah, my question is, your line of questioning is assuming that that percentage of people who are not impacted by coverage in terms of whether or not they take the drug is a large percent of the population.
We don't know. I mean, I don't know. I mean, what fraction is
Yeah.
it? I don't know. But it's not, you know, you're assuming that
So from the time that, so I think that's changing, right? So when we did this research starting, you know, a year and a half or 2 years ago, I think that group was really small. And that there's also this issue that there's not even supply to really, you know, provide all of these people with treatment, but that group paying out of pocket was small, and that there's over time increasing ways to get these drugs from compounding pharmacies and stuff like that, so that the cash pay market has increased. I don't have a good sense of how big of a portion of the population that really is.
Alison, thank you so much. We have like some questions from the virtual audience. Kira or
Maybe we
Susu?
can give her more, because we interrupt a little bit. We can give her more of the time.
Yeah, we are.
I'm
almost
happy
up.
to answer. I'm happy to answer questions
Yeah.
too. And I think like the only remaining slides are sort of talking about the fact that the value of treating obesity is large, and that we need to have conversations around how to expand coverage and access to the drugs, and whether that's you know, different types of pricing agreements between manufacturers and payers, and you know, how do we get to that? There's also a slide that is, in case people aren't steeped in all of this, AEI put out about a year ago or a little bit less, and used SR Health data. I think this is, which slide is this? It shows what the average net prices are. Slide 30 shows what average net prices are for the drugs, which is much lower than list prices. But yeah, I'm happy to answer questions or discuss policy around how to pay for these drugs.
Kira? Questions from the audience, virtual?
Yeah, I can read them out, or if you all want to come off of mute. We had Joel, your question first. Are you including the dropout rate from side effects?
Yes, there's significant evidence of severe GI side effects, so much so that probably 10–15% of people drop the treatment. And this may be more severe in the geriatric population, which would obviously affect the Medicare coverage issue. Are you modeling that? I mean, for you to get the benefit of this treatment, people have to stay on it forever. And there's significant evidence that when they drop treatment, they regain, probably about half of people regain a significant part of the weight loss within a year's time. And there's every reason to think that will continue. And so are you including that in the modeling? Because if not, then you're overstating your benefits substantially.
So we aren't saying these will be the benefits. We're saying these are the potential benefits, which is the language we've used because we've made these unrealistic assumptions around uptake and continuation. And I will say that there are versions with the same simulation model that have been looking at lower weight loss and much smaller uptake and the discontinuation piece of all of that published. This paper is not taking any of that into account. I will say the data is not there for these drugs yet. There's been a few claims data analyses, and the discontinuation rate is even higher than you're stating. So I think we just don't know yet what the future will look like 10, 20, 30 years from now in terms of how people are taking these drugs. And even since I started this particular paper to now, the weight regain has changed. That we're learning how to treat patients and help them off the drugs at the end of all of it. So the initial trials showed a huge yo-yoing impact of weight. And I think the actual use scenarios of this, physicians are finding ways to help patients come off in a less drastic way. We considered other scenarios. We measured the value if patients had their immediate 20% reduction in BMI and then returned to their pre-treatment weight gain trajectory. So for most people, that's steady weight gain through your sort of early 60s, and then people tend to lose weight once they are retirement age. So we looked at that, and the value is almost just as high in that as also sort of keeping the weight off over time. There's huge value in getting that weight reduction as long as you put the weight on slowly again afterwards. We did not model any sort of immediate rebound, because tied into all of that, there would be, I think there's cardiovascular impacts from losing and gaining weight that quickly. And so all of that stuff would be sort of guessing at what uptake and discontinuation will be and what those health impacts of gaining the weight back really fast would be. So we, with this study, tried to keep this hypothetical, looking at what the total pie is in terms of value of treatment.
Thank you, Alison. We also have other questions from the audience, virtual audience. Kira, would you like to?
Jessica, do you want to ask your question?
Yeah, so I was actually curious about using BMI as the measurement tool, because there are some people who say it's kind of outdated and it's based on men's bodies and doesn't necessarily account for muscle mass. So are the benefits that you're talking about only assessing a change in BMI, or are there other health factors that you consider?
So the way that the model works is it's a series of regression equations predicting what happens to patients cycle over cycle. So it's a 2-year cycle. And so we use all the information we have on patients in terms of their health characteristics, their economic and household characteristics, their race and ethnicity and age and all of that stuff to predict what happens to them in the next model cycle. So BMI is a factor in predicting whether or not you get diabetes and heart disease and many, many other outcomes. But yeah, it is the weight related impacts in the model are all driven through BMI, but we're modeling it flexibly in splines so that it's not just an obese, not obese. So I think although we have questions as a medical community around whether or not BMI is the right measure to look at for patients' health, I think BMI works from a modeling standpoint for our simulation.
Do you know what fraction of demand is female versus male? Is that out there?
I haven't seen anything on that yet. Do you have hypotheses?
I live in Florida and pretty much everyone I run into is a woman who takes it and not a man, but that doesn't mean men take it and don't talk about it as much, maybe.
I was going to say the opposite here in California,
All right.
but
Okay.
maybe I'm hanging out with men and you're hanging out with women.
Yeah, exactly. It's like, you know, the surgery, the fat removal surgery. What do you call that?
Gastric bypass.
No,
Gastric bypass.
I haven't had it yet.
Anyways, the men hide it more than the women.
I mentioned what I research, and immediately, like, over half of the people that I interact with through my kids' sports and stuff like that, then, you know, immediately are interested and talk about their use experience with it. So I think in certain affluent populations, the demand, regardless of insurance, is there for sure.
Thank you. We can have one more questions, and then after that, we have to wrap up. Daniela, you have a question? Do you like to ask that question?
Sure, I'm sorry for the background noise. Yes, hello with everybody. I would like to ask, I remember that Medicaid used to cover the intake of orlistat like probably 20 years ago or so. So I would like to know if you have like information about it, if you have made like a study about it, like an impact study or something like that, or if you have information about that topic. And I also would like to, well, you already explained, my other question was about the estimation method. So you already kind of explained a little bit further about that. And that was pretty much it. Thank you very much.
Yeah, I'm sorry. So you're saying that Medicare used to cover a previous weight loss drug? Is that what you were suggesting? Sorry.
Yes. So I don't know if you know like the impact of Medicaid covering that.
Oh, Medicaid.
So yes, because I remember it used to cover it. I'm not sure though.
Okay. Yeah, I mean, there are
That's cryptic.
several states that have Medicaid coverage for these drugs. And I think that's sort of changing over time too. Medicare Part D has never covered a weight loss drug because it's written into the statute that it can't cover. But yeah, any weight loss drug prior to the GLP-1s has been met with a lot of I think there was like fen and stuff like that that had a lot of demand initially, but the side effects were too great. And there just hasn't been a weight loss drug that has actually resulted in consistent and significant weight loss. So there aren't a lot of studies out there looking at the impact of drugs on sort of the long-term benefits of weight loss. There are studies looking at how weight impacts other outcomes, and we're looking into, you know, trying to model how the obesity epidemic has been tied to the pain epidemic and things like that. But that goes certainly beyond what your question was.
Thank you so
Yes,
much,
thank
Alison.
you.